Nikki here. Welcome to part 2. We are going to talk about the uterine cycle and finish up this chapter on reproduction. Uterine tubes. So a lot of terms coming your way, things we've kind of already talked about a little bit here and there. Used to be called fallopian tubes. Remember, we're trying to get away from eponyms. So uterine tube, you're going to have 2 of them. There's going to be one on each side as it heads towards the uterus. And then we're going to look at the different sections of the uterine tube. So the infundibulum, it's this free funnel shaped end of the uterine tube, and it's going to have lots of folds on it, finger-like folds, and those are the fembrae. It only comes to touch the ovary at the time of ovulation, and these fembrae sweep the ovary and take the secondary oocyte into the uterine tube. So just something to note, we've talked about it before, that this is not directly attached. So the uterine tubes are not adhering to or bound to or ligated to any part of the ovary. Some more sections of the uterine tube is the ampulla of the uterine tube. Again, make sure that you're being very clear, because we also have the ampulla of the ductus deferens, right? So this is an expansion part. It's kind of the curved section. We'll have an image in just a second. And this is typically where fertilization happens. You'll have people that'll argue about it. Isthmus is a narrowing, and we'll see that on the image in just a second. I like the way that they've color coded this and kind of broken it down. Here's our ovary. We can see the little fembrae. The fembrae are the most distal section, right? The little fingers. This whole section, this cone-shaped section, is the infundibulum. And once it makes kind of this curve, that's the ampulla. So this, for us, is going to be the site of fertilization. Why do I say for us? Because some people argue that it happens at the infundibulum. Either way is fine, but we're going to stick with the ampulla of the uterine tube. The isthmus, when it narrows here, and then we have the section where the uterine tube actually makes it to the uterus. So this is the uterine section. We can also look at the uterus itself and see the different linings or layers that we're going to get ready to talk about. So the uterus is pear-shaped. It does have an opening. Remember, lumen just means opening. And it is usually angled anteriorly, so towards the front, right? It can shift, and I'll show you a picture in just a second. It can shift posteriorly in older women and project towards the rectum. So here's what we mean by it's facing forward. It's sitting directly on top of the bladder here. So sometimes the uterus can flip, and then it would be pushing into the rectum, and you could imagine that would be uncomfortable, cause constipation, things like that. So uterus functions, lots of functions here, right? Implantation for the pre-embryo. This is kind of a new term. We usually just say embryo, but they're talking about before it actually starts making its embryonic tissues, things that we'll discuss when we get to the next chapter. So the uterus is also going to support and protect and nourish the developing embryo. It's going to create a vascular connection. When we talk about the placenta, I'll give you a little bit more information. This is also, the uterus has to contract to eject the fetus at birth. We talked about this way back in 201 when we talked about positive feedback. I gave an example of how childbirth, right? The oxytocin receptors, oxytocin being released, contraction of the uterus pushes the baby's head on the cervix, and then we just keep that positive feedback going. Also, the internal lining, the endometrial lining, is going to contract, and, well, the muscle is going to cause the internal lining, the endometrium, to contract and shed off if there is no fertilization. And the uterus receives blood from the uterine arteries, and these are off of the internal iliac. So just a note, right? We talked about abdominal aorta, and we talked about our gonadal arteries and veins, and we talked about if it's going to the ovary, and we talked about ovarian arteries and veins. So what they're saying is the branch off of the iliac is where we have our uterine arteries. You can have pregnancy outside of the uterus. So if the fertilized oocyte implants outside of the endometrium internal lining of the uterus, you could have a tubal pregnancy. So it's just one of the many types of ectopic. So ectopic just means outside of, right? Not in the right place, not in the endometrium of the uterus. The fertilized egg can implant in the uterine tube. It's only viable till about 8 weeks. It doesn't have enough nourishment in the actual tube for the embryo to grow and expand and get enough blood supply, be able to develop those extra embryonic structures, and be able to develop a placenta. So the uterine wall can rupture, and this would cause leakage into the pelvic cavity, right? Hemorrhage, loss of life, even possible. The uterus, we talk about regions. So not only are there 3 layers of the uterus, but there are also regions of the uterus. The fundus is kind of this rounded top region. Then we're going to see the body, the middle region. Then we're going to see a narrowing as we're headed towards the cervix, and then we'll see the cervix, which projects into the vagina. So here, this image, the rounded part is the fundus. This is the body. Then you can see the cervix here, and they want to make sure you see that the cervix actually dips into the vagina. Here are the walls of the uterus. You can see the internal lining we keep talking about, the endometrium. All of this is muscle, myometrium, and then we have this outer layer, which is the perimetrium. There's also a cervical canal. There's a small area through the cervix. Remember, the cervix is going to have to dilate when we talk about childbirth, right? There are these internal os, external. It's basically just the top opening of the cervical canal or the bottom opening. Lots of epithelial cells here. There's also a mucus plug. So there are mucus secreting glands, and basically this prevents pathogens from invading the uterus from the vagina. So I'll show you a picture again, but remember, if you have the uterus here and you have the cervix here, and then you have the vagina, this is kind of that line between the external environment and the internal environment. So if I have a narrow canal in my cervix, I want to make sure that the majority of time that is blocked up with this thick mucus, right? So that any pathogen can't just make its way from the external environment straight into my uterus, which has a direct blood supply, right? Also remember that this is going to thin, kind of bring us back to some of the male information that we learned. Remember the seminal vesicles also bring with them prostaglandins. I'm going to abbreviate there. And those prostaglandins help thin out that cervical mucus so that the sperm can make their way into the uterus and out to the uterine tube, specifically the ampulla of the uterine tube, to fertilize the egg. We do have supporting structures of the uterus. So the muscles of the pelvic floor help keep the uterus in place, and there are lots of ligaments that are anchoring it to the pelvic cavity. But there is something called uterine prolapse, where the uterus falls down and starts to protrude through the vagina. You could see how the weakening of the pelvic floor muscles or the stretch of the ligaments supporting the uterus could allow for this to happen. In this image here, you can see several of the ligaments, right? So ligament here, and here, and here. And all of these ligaments are basically keeping the uterus in place. So if something were to happen that those ligaments were stretched too much just through age or multiple childbirths, the uterus will start protruding into the vagina. And in some cases, it can hang outside of the vagina. So this is something that can happen in older patients. And while we're here, I'll just have you look at the uterine blood vessels. So these are the blood vessels that are coming off of the internal iliac, and then here are the ovarian blood vessels that are coming directly off the abdominal aorta to feed the ovary. We also have layers or tunicas of the uterine wall. I kind of already showed you those, the endometrium, the myometrium, the parametrium. The endometrium is the lining that is shedding off every month during menstruation. Here you can see again, endometrium, myometrium, parametrium. So the vagina is a fibromuscular tube. It is going to connect the uterus to the outside of the body, right? External environment. Functions as the birth canal, receives the penis during intercourse, and it's the passageway for menstruation or the shedding of that endometrial lining. There are also 3 layers of the vagina. So there's an internal mucosal layer, there is a muscular layer, and then there is this fibrous, elastic adventitia. So this is something we see quite regularly. There's going to be some sort of internal epithelium, then you're going to have some sort of muscle in the middle, and then you're going to have some sort of fibrous connective tissue offering support on the outside. So endometriosis is when that endometrium is growing on other organs, right? So somehow the endometrial tissue comes out and it implants on the surface of other organs within the abdominal pelvic cavity. And when I say it somehow comes out, remember you have your uterus here, and then we have our uterine tube, maybe not the best picture, right? Uterine tube. Remember, it's free at the end, it's not attached. So we could have endometrial tissue that makes its way out of the uterine tube, and let's say it starts growing in patches on the ovary, or it can start growing in patches on the outside, the fundus of the uterus, right? It is still under the influence of hormones. It can't be gotten rid of the normal way where we push it through the cervix and through the vagina. So it can cause pain and scarring. It's often linked to fertility issues. And we can treat with hormones like birth control pills to try to lessen the growth of endometrial tissue to begin with. You can also do surgery where you can, they can do laparoscopic, go in and burn off the areas, the excess areas of endometrial tissue. Cervical cancer, this is what we do a pap smear for. So female, and you get a yearly checkup or every 3 years, and they swab the inside. They're taking a sample of cervical cells and they're growing them up to see if there's any sort of abnormal development. Early stages of cancer can be detected from a pap smear. It's caused by this human papillomavirus. There are many, many different strains of HPV. So the 4 most common types that cause cervical cancer, we do have a vaccine for. It's called Gardasil. Can be given to both males and females who are sexually active or before they become sexually active. If you are sexually active, you probably have been exposed to multiple different types of or strains of HPV. Not all are symptomatic. So a lot of us, if you hear HPV or human papillomavirus, you might think of things like warts, just like a wart that you would get on your hand. You might think of genital warts. But just, I guess, to clear the air, it's not every single HPV is going to cause some clinical or visible issue, right? There's a few strains that can cause cervical cancer and a few strains that are responsible for some STDs. Uterine cycle, most of us can look at these phase names and probably figure out what's going on, right? There's a menstrual phase, there's a proliferative phase, and there's a secretory phase. So we usually base this on a 28-day cycle, but remember, everyone is a little bit different. Some people have shorter cycles, some people have longer cycles. So the menstrual phase is the first couple of days. This is when you're actually bleeding. The proliferative phase is when you're building up new endometrial tissue. And remember, this is going to overlap with the follicle growth, and I'll show you a picture in just a second. So now we're in the secretory phase. So we've already done ovulation. So this is day 15. Remember, about day 14 is when we'd say, in this example, where ovulation would occur. So the secretory phase is when you're going to see an increase of progesterone being secreted from the corpus luteum. So we remember that when the secondary oocyte is ovulated, the remaining granulosa cells turn into the corpus luteum and secrete progesterone, right? So this is going to cause increased vascularization in the endometrial tissue. If fertilization does not occur, remember the corpus luteum is going to break down to the corpus albicans. You're going to see a drop in progesterone, and that is going to cause the endometrial layer to slough off, and then you'll be back at the menstrual phase again. So I kind of chopped up that nice figure just to show you what's going on in the ovary and the uterus, right? So we know that that follicle is maturing. So you can see the follicular phase of the ovary correlates to the menstrual and the proliferative phase in the uterus. So this is when you're actually bleeding, right? Some people bleed 2 days, 3 days, 4 days, 5 days. Some people bleed a week out, right? So about day 14 is going to be that ovulation where we eject the secondary oocyte from the ovary. And you can see that the lining is building back up in the proliferative phase. And that's due to this high level of estrogen. Where's the estrogen coming from? It's coming from those granulosal cells as the follicle is maturing. Then we can see that the progesterone is really high in the luteal phase, right? So that's directly related to the corpus luteum secreting high levels of progesterone. And you can see that there's a lot more blood vessels, right? So high degree of vascularization, and then we have this nice thicker endometrial lining. So remember, day 14 here is when we eject the oocyte. The sperm has to penetrate that oocyte, and then it has to travel down the uterine tube. And we said it takes about 7 days to get there. So the fertilized egg gets to the uterus at about this point, when the lining, the endometrial lining, is at its thickest, and it has lots of blood vessels, so that when that fertilized egg, that pre-embryo, embeds into this endometrial layer, it has a ready blood supply from mom. Now we're moving on to the female external genitalia. You can see here the terms mons pubis. This is basically kind of the fat cushion. It sits in front of or anterior to the pubic symphysis. It is covered in pubic hair as an adult. Labia majora, this is the thicker outer fold. It is homologous to the scrotum in the male. It is covered also in pubic hair, and there are lots of sweat glands and sebaceous glands in the labia majora. The internal folds are called the labia minora. These are highly vascular. There is no hair. Again, lots of sebaceous glands, melanocytes. They mentioned this, you can have moles on external genitalia, right? The vestibule is the space between the labia minora. It's where you're going to see the opening of the urethra and the opening of the vagina. Then we have some erectile tissue that we're going to see. This is going to fill with blood during sexual activity. So there's the bulb of the vestibule, and there's also the greater vestibular glands. These are going to secrete a mucus, kind of like a lubricant for the entryway of the vagina. A lot of people will talk about these being homologous to the bulbourethral glands. Right, bulbourethral glands not only clean out the urine in the urethra, but they lubricate the glans penis for intercourse. So greater vestibular glands also serving that purpose. The clitoris, this is a small erectile body. There's lots of nerve receptors, and you're going to see some terms that we've used to describe male external genitalia. They also have 2 erectile bodies, corpora cavernosa. These are going to fill with blood, increase sensitivity during intercourse. So there is a glans penis and there is a prepuce. So this is prepuce in males and females. In males, we call it foreskin. Prepuce in females, it kind of looks like a hood over the clitoris. So you can see here maybe the hood, that's the prepuce. This is the mons pubis, the fat cushion. You can see the outer folds are the labia majora. You can see the inner folds are the labia minora. And then inside the vestibule, you can see the opening for the urethra and the opening for the vagina. And you're also going to see openings here at the bottom, and that's where you're going to see the mucus that we talked about to help lubricate the vagina. So here are the bulbs of the vestibule and the greater vestibular glands, and they're going to, like I said, have openings right here to help produce mucus to lubricate the vagina for intercourse. I think you can see here the body of the clitoris. It's pretty interesting. It does have kind of like a cap on the end, that gland, just like we saw in the glans penis. So clitoris homologous to penis. Now we move on to the mammary glands. So these are going to secrete breast milk, right? What is in the breast milk? Proteins, fats, sugars, all of this to supply the infant with nutrition. For breast or mammary gland components, we have the nipple, we have the areola. The nipple has multiple tiny openings, and this is a way for us to transport the breast milk. And this areola is the pigmented ring around the nipple. So you're going to see lots of sebaceous glands, and it can darken in women who have given birth due to all of the high levels of hormones during the creation of the embryo and the fetus. We also have suspensory ligaments. So fibrous connective tissue that helps support the breast, and the breasts sit on top of the pectoralis major. Again, fibrous and ligaments. So what's going to happen over time as you age, you're going to have decreased tautness, right, of these ligaments. So breasts do sag as just a natural part of aging. If we actually look at the lobules that are producing the milk, there's several different terms. Some people call them alveoli. Some people don't like this term because we talk about this in respiratory too as alveoli sacs. So you're going to see in the lab book that they refer to them as lactiferous lobules. These lactiferous lobules are going to channel the breast milk into lactiferous ducts, and then there's this expansion or a sinus where we can store some of the milk. So this is a nice example showing you the suspensory ligaments. You can see the fat, the outer layers of adipose tissue. You can see the lobules, the lactiferous lobules. And then if you look carefully, you can see that the lobules lead to lactiferous ducts, which then lead to lactiferous sinuses. So that's kind of this bulge here where we can store milk. And then all the lactiferous ducts merge right here at the nipple. So that's what we mean by tiny openings. And then you can see the areola here. It is a thicker tissue. Think about breastfeeding. If you didn't have this thicker, pigmented, more durable tissue during breastfeeding, it probably would be even more painful. Lactation. Go back to our wonderful hormones that we had to know so much about, right? So remember, prolactin is secreted from the anterior pituitary. This is going to target the mammary glands to produce more milk. The alveoli are going to enlarge. Those lactiferous lobules are going to enlarge. The oxytocin is responsible for milk ejection. Remember, oxytocin is made in the hypothalamus, but it's stored in the posterior pituitary. It was only one of the two posterior pituitary hormones that is released. And you need both, right? So you need prolactin to make the milk. And then upon giving birth to a child, oxytocin is high enough level that it causes the milk to be ejected. So here we have a slide on breast cancer. You can see it occurs fairly common in women in the United States. It can be family history. That's where these genes come in. These are tumor suppressor genes, so they suppress tumor growth. If you have a defective copy, or you're missing one, or you're missing both, it increases your risk of cancer. It doesn't mean you're going to get cancer, it just increases your risk, right? So there's lots of other factors like exposure to estrogen, environmental factors, obesity. There is also something about when you have your first pregnancy. So if you have your first child under, I think, 30, you've decreased your risk. And if you have a child later in life, you've increased your risk. Also, mammograms, right? We should be getting mammograms over the age of 40. This can detect malignancies early on and treat them before it metastasizes. Remember, the breast tissue is right next to the lymphatic tissue right there in the axillary, where we have lots of lymph nodes. And while this is good to clear up any pathogens, it may not be great for cancer, because if the cancer cells get into the lymphatics, they can spread to anywhere else in the body. The last couple slides, we'll go through the stages of female sexual response, and then we'll end talking about birth control. So the female sexual response, you'll see, begins with excitement phase. The reproductive organs are going to engorge with blood. Remember, the clitoris has the corpora cavernosa. The nipples can become erect, and the uterus, instead of laying kind of flat, can move up just a little bit. Vestibular glands, vaginal walls are all going to produce mucus. You're going to have a slight constriction of the vaginal wall, an increase in heart rate, blood pressure, respiratory rate. So there hasn't been as much study about the neurological responses, but we're going to say for this excitement phase, the arousal phase for females, for the majority, this is the sympathetic nervous system. And again, they don't really understand all of the autonomic system stimulus for female sexual response. So during an orgasm, there's intense rhythmic pleasure. You're going to see the vagina is going to contract and the uterus for several seconds. And also there's something called reverse peristalsis. So if my uterus is here, my cervix here, my vagina here, the contractions are rhythmic in nature to hopefully pull the little sperm through the cervix and into the uterus, and then hopefully out to the site of ovulation. Resolution phase, the uterus returns to its normal position, the vaginal wall relaxes, the excess blood is going to leave the corpora cavernosa and the clitoris, and there is no refractory period in women. They can have multiple orgasms back to back. We talked a little bit about menopause already. Most books now say about 45 to 55. You are going to have the atrophy of reproductive organs and breast tissue. You're going to have decreased thickness of the vaginal wall, and the uterus is going to shrink a little bit. There are hot flashes associated with menopause. Basically, you have less control over your body temperature. It's something to do with your hypothalamus controlling body temperature and what it senses as, oh my God, we're going to die, right? Maybe when your body temperature only changes by a degree, but in your hypothalamus, it's registering as 10 degrees difference, right? We're also going to see thinning scalp, increased facial hair. Remember, there's an increased risk of osteoporosis and heart disease in menopause. So estrogen really provides kind of a protective barrier to osteoclast activity. Remember, osteoclasts break bone down. So estrogen kind of calms them down a little bit, if you will. And then when we remove that estrogen, all of a sudden those osteoclasts start breaking down bone. So the first 5 years after menopause, you really have to pay attention to osteoporosis. Make sure you're taking enough calcium and that you don't have increased bone breakdown. Sometimes symptoms can be treated with hormonal replacement therapy. You'll see it abbreviated as HRT. If you're taking hormone replacement, it does increase your risk for several types of cancer: ovarian cancer, cervical cancer, uterine cancer. So many physicians have stopped prescribing. Why do we still have this? Imagine if you had to have a full hysterectomy when you were 20, you may want to do hormone replacement therapy. May not want to go through menopause at 20. Some of these things like osteoporosis. At 20, you don't have your critical bone density, right? You're not at 80%, 100% of total bone growth. So in some cases, hormone replacement therapy might be prescribed, but as you age, taking hormones as a replacement does increase your risk of cancer. Now on to the contraception methods. So if you're trying to prevent pregnancy, abstinence is the only 100% way, right? There are other methods like the rhythm method. So avoid sex during ovulation time. The withdrawal method, so pull out before ejaculation. But remember that if you have intercourse multiple times, that there could still be some sperm left in the urethra when the bulbourethral glands clean out the urethra. So it is still possible to get pregnant with the withdrawal method. Lactation, and I'm going to point right here to temporarily. So the release of prolactin to make the milk and oxytocin to eject the milk can temporarily prevent FSH and LH release, which then would prevent ovulation. But it is temporary. I know lots of people, they're breastfeeding at 8 months and they're like, oh, I can't get pregnant because I'm breastfeeding. Nope, that is not true. I know lots of people that have children less than a year apart because they thought that breastfeeding was going to prevent pregnancy. There are also barrier methods, right? So condoms, you don't allow the sperm to get into the female reproductive tract. Some condoms have spermicidal jellies just in case some of the sperm happen to make it out. If there's a tear in the condom for some reason, the spermicide will kill any of the sperm. And then sometimes people use spermicidal gels with diaphragms. So diaphragms are this kind of plastic piece that you insert, and it blocks the entry from the cervix into the uterus, so the sperm can't get past that diaphragm. So again, just to kind of, what could you do with the rhythm method? You can take internal body temperature, right? And as estrogen rises, your body temperature is going to creep up just a little bit. And you would have to take this for a long period of time to know, kind of set the foundation so that you know. Because remember, not everybody is 28 days, right? So you would have to figure out exactly when you're ovulating here and try to avoid having sex during that time. Something we don't know yet, sperm can live for 2 days. So you kind of have to have a 2-day window on either side of ovulation, and you have to know exactly when you're ovulating. Some people like to just use time, but you have to be careful because when does day 1 start? It starts on the first day that you're bleeding. So let's say you bleed for 5 days, and this is the day that your period stops. Some people are counting 10 days from here. Well, you might actually ovulate on day 14. Some additional contraception methods, we have an IUD. An IUD is a flexible plastic structure that's inserted into the uterus. I'll show you on the picture in just a second. It can also have hormones that are being released continuously from that device. Oral contraceptive, here we're talking about birth control pills. And there's all different kinds, right? Usually they're going to prevent a spike in LH that will prevent ovulation. You can also have injectable progestins, so progesterone. This will prevent ovulation. Remember, if your progesterone is really, really high, you're waiting to see if the secondary oocyte got fertilized. So basically, you're tricking your body into thinking that you're waiting to see if you're pregnant or not. So it won't start the cycle over again. So you won't have another secondary oocyte ovulated. So basically, all of these are messing with the ovarian cycle where the secondary oocyte is ejected. Same thing with this morning after pill. So morning after pill, this is not an abortion pill. So I've heard people refer to it as that. All this does is inhibit ovulation. So it's very similar to oral contraception. The only thing is you take this within 72 hours of unprotected intercourse, and hopefully you'll inhibit ovulation. So even though the sperm are hanging out in the female reproductive tract for 2 days, if no egg is released, then you won't have a pre-embryo or a fertilized egg. Here in the uterine wall, you can also have the IUD structure. So I just wanted to show you what it looks like. It's this T-shaped, it binds, it's attached here, and it would stop the secondary oocyte from implanting. It can't get through here to implant. Last slide here. There is a contraception method that could be called an abortion pill. This particular drug, sometimes called RU486, induces miscarriage. So it actually blocks the progesterone receptors. And remember, high progesterone is what's keeping that endometrial lining intact, right? So remember that the placenta doesn't develop for a couple of months, and so having this high level of progesterone from the corpus luteum allows for the pre-embryo and the embryo to embed in the endometrial lining. So if I give you a drug that blocks all of the progesterone receptors, that pre-embryo and all of the lining is going to slough off the inside of the uterus. So that would induce a miscarriage. Tubal ligation, you cut the uterine tube, you tie off the ends or cauterize, burn them. It prevents the sperm from reaching, this should say, uterine tube site of fertilization. Remember the ampulla. So basically, cut a section of tube, cauterize the ends, tie the ends off. The sperm can't jump over this cut section. Same thing with vasectomy, except for you're cutting the ductus deferens, you're removing a section. The sperm are unable to leave the testes. That doesn't mean that there won't be any ejaculate. Remember the seminal vesicles, the prostate fluid, the bulbourethral gland. So there'll still be ejaculate, just in the semen there won't be any sperm. Okay, well, we have finished the reproductive chapter. The next one we will talk about is development. Talk to you soon. Bye.